This is a slide of Sierra Leone. It's the rainy season, halfway August, or actually beginning of August, just before I was asked or demanded to leave Sierra Leone by my organization. It's a disclaimer. I want to make sure this is the story that I tell from March till August. At the moment it's November, the story changed. It is different at the moment in Sierra Leone, but this is what happened in the first months of the outbreak. My name is in the bottom. I'm the medical officer in charge of Masanga Hospital. I work there together with a colleague, Bart Walewijn, and he is the international coordinator of a surgical training program run by Care. Before I start the presentation, I would like to use your time and your attention to look at these photos. This is Joseph, and Joseph is our colleague, or was our colleague. He attracted the virus, he passed away. He infected his family, his father, his mother, his brother, and his wife, and they all passed away. And from a personal point of view, that has been very difficult for us, even though it was after we have left the country. But of course, we know about the story, we know him very well. We work with him every day. And this is just one of the patients. You see all the numbers, 10,000, 13,000, 5,000. And this is one of them. So please have him in memory during this presentation. Brief overview. This is Sierra Leone. There's a red dotted line. That's the Tonkolili district. That's where our hospital is. There are around 500,000 inhabitants in the district. There are 3 hospitals. One governmental hospital in Maburka, one NGO hospital in Yile, and one partly governmental, partly NGO hospital in the district, and that's our hospital, Masanga Hospital. We are a general community hospital, around 100 beds, 90 staff. We have a Tonkolili College of Health Sciences. We run training for state and world community health nurses, 100 a year. And we run a surgical training program under the name of Care. And we train community health officers to become community health officers with surgical experience. And the idea is that they stay in the country, they will work in district hospitals, and they will serve the communities after they've finished. We opened in 2006. Since then, treated nearly 200,000 patients. On a yearly basis, these are the numbers of 2012. 500 deliveries, 1,200 surgeries, almost 4,000 admissions, and 17,500 patients seen in the OPD. We are not for free, but we do run a cost recovery program. It's a minor fee just to keep up with the expenses, and we only give free healthcare as demanded by the government to under 5s, pregnant women, and lactating women. And this has to do with the Millennium Development Goals and achievements, because child mortality and maternal mortality is still very, very high in Sierra Leone. A couple of photos. This is our emergency unit, the only emergency unit in the district. This is our OT. This is me and Bart doing a cesarean section. This is our surgical ward. And this is very short how life was before the Ebola outbreak, because we were there from the beginning of the year. And this is how it was. So it was teaching, surgeries, but also having a good time if you're off in the weekends. And this is how it became. The upper left is our ward, the surgical ward, and you see a yellow tape around the ward. And that's when we had our first suspected case in the hospital. The photo below is not from our hospital, but it's exactly the same as what we did. We had to do a burial ceremony. We had to dress up in full personal protective equipment and do a burial next to our hospital. If we look at our first 3 cases, we have to go back months ago. We have to go back late March, early April. We had our first 3 suspected cases. And at that time, there was no official case definition made by the Ministry of Health or the government of Sierra Leone. We had no supportive treatment protocols. We didn't know what to do, actually. There was no isolation unit in the hospital. We didn't have PPE, personal protective equipment. We didn't have an outbreak protocol for our hospital. We had an incinerator, but it was not really working. We had no body bags. Burial ceremonies were unclear. And when we asked the district team to come and assist, they had more questions for us than answers. If you Google at the moment, you go to the website of WHO, CDC, it will always be difficult not to find a protocol or not to find a guideline. But when I speak about May, June, it was very, very hard to find guidelines, very, very difficult to know what to do at that time. We found a guideline from WHO, CDC, infection control for viral hemorrhagic fevers in the African healthcare setting. And that really fitted to our hospital because we are a hospital in the African healthcare setting. And this is the advice that you get. This is the PPE that should be sufficient. This is the PPE that is being recommended at that time. And this is the PPE, how we dressed up and how we approached the patients in our surgical ward. Then we said, we need to have somebody in the hospital. We need to have an Ebola coordinator. Somebody is going to coordinate every suspected case, who's going to be a member of the task force in the district, but also in Freetown. We have to set up an isolation unit. We have to set up a screening area. We have to teach our healthcare workers. And we also have to inspect neighboring hospitals. Because if we become the best prepared hospital in the district, and our neighbors, they don't prepare, then we will become a referral center. So what we did, we wrote an outbreak protocol for our own hospital. With the protocol, we tried to find funds. We found funds in Denmark through the Lions Foundation. And the protocol describes 12 steps. But the most important step is maybe the last, and that is to ask for help. And what we did is that we contacted somebody in Norway who has experience with MSF, who worked in the field, and we asked him to come to our hospital and to assist us. Because we can set up our units until a certain level, but sometimes you need to have a more experienced person to assist you. And the most important was that we need to screen. And it has to do with what we do in hospital. What we do is we run a surgical training program. And the difficulty is if somebody comes in at the emergency unit or at the OPD and you think you have to do an emergency surgery, how can you be sure this patient is not an Ebola patient, but an ordinary patient? How can you be sure that this acute abdomen, how it looks, clinically, is due to a perforation of the terminal ileum and not because there's all kinds of symptoms that could fit to Ebola? So what we said, we need to screen, and we need to screen everyone. So we built a small screening hut at the outpatient department. It's in the blue, in the right corner. And every patient had to enter. And we made a physical barrier. It's very basic materials, but we said the healthcare worker has to stand behind the physical barrier, and we run it through a questionnaire. And the questionnaire has 3 sections, section A, B, and C. A relates to fever, temperature, B relates to travel history, and C relates to complaints. And if you have a combination of A, B, and C, or B and C, then the patient becomes a person under investigation. The medical officer has to come, and you have to make clinical judgments. Is this somebody who we're going to put in isolation? Is this somebody that we're going to do an emergency cesarean section? Is it somebody that we don't even know what to do? We did the same at the emergency unit. We closed all the doors of the emergency unit, only left the back door open, cut the door in half, thereby creating a physical barrier, asked all the questions to every new patient, and we distributed laminated cards. And these cards, they contain all the information, all the steps that you need to take in case you have a suspected case coming to your hospital. If we come to the isolation unit, I think all of you have seen photos of isolation units set up by big international organizations. This is an isolation unit being set up in the jungle of Sierra Leone, so without a proper budget. What we did is we looked where is the most remote ward on the ground that we can use, and that is separated from the ordinary wards. And we found one at the periphery of the facility. And we said we need to have a special donning room where you do on your PPE. We need to have a doffing room where you do off your PPE. We need to have 3 beds minimum. And we need to have facilities to go to the loo. Preferably 1 toilet per patient. If you look at the photos, you will see that it's quite basic. The left side is very difficult to see, but it says isolation area, stop, authorized personnel only behind this point. And on the photo on the right, you can see the structure. That's the ward that we use. There's a big tank, a Mila tank, and the tank is placed on top of the structure next to the ward. And in the tank, we made our own water, our chlorinated water, connected to pipes. Pipes go in the unit, so we had chlorinated water in the isolation unit. And this is from the inside. Basic, but sufficient. These are rice bags bought on the market. We brought the rice bags to the tailor. The tailor cut them open, sewed them together. We asked the carpenters to come in. They sealed the rice bags from the ceiling to the floor, and thereby we created separate areas. And then we said, in the dressing up room or the donning area, we need to know how to take it on. So we just put on all the steps on the wall, and together with the body and somebody who's checking us, we did on our own PPE. This is from the inside, the isolation unit, a bed, again, plastic sheets to separate the beds. And we said we need to have the bed next to the window. And then we can put the caretaker at the window, and then the caretaker can at least see what we are doing. Because if we're going to bring in a patient that is still alive, the patient comes out, the patient passed away, and nobody sees what we've done, you will get all kinds of rumors going around. And of course, also for the comfort of the patient to have somebody close to him. In the lower left corner, you see a cupboard. And the cupboard was stuffed with all the medicine and all the caring equipment that you need to take care of a patient for 48 hours. Because once you're in, it's impossible to go in and go out all the time. So we need to have all the equipment readily available. So we had medicine in there, we had catheters in there, we had IV fluids in there, all to keep the patient treated. And in Sierra Leone, it's still a situation that you take your own blood sample, you send your sample to the lab, and then you wait until you get your result back. In our situation, we had to wait up to 80 hours sometimes. So that means that you have to go in 3 times a day, 2 doctors, with somebody from the lab and a cleaner, 8 people per day. Everybody needs to dress up in full PPE, 8 suits per day minimum. And when I speak about June, July, there were only 40 suits available in the whole district. And then we tried to order our own suits. And then we heard they're not available. Maybe it takes a month, 1.5 months. And then hospitals all over the world, also in Holland, they were preparing themselves for possible Ebola patients. Suits were flown to Groningen, Amsterdam, Maastricht, but not to the district. This is the water supply that we connected ourselves in the isolation unit. And this is the doffing area, where you take off your PPE. It's a little bit bigger than it looks on the photo, but what we did is very simple. All the steps are printed out, put on the wall, and in the end with 14 or 15 steps, and you just go from step to step to step, and at step 15, you're out of your suit, and you're clean, and you can step out of the room. Unfortunately, it didn't help. At least, I'm standing here, I'm not in Sierra Leone, I'm asked to leave the hospital, and the hospital is closed at the moment. What we saw were major problems on national but also on district level. In June, July, August, there was not a big response yet. Not from the big international NGOs. They were not present and not supportive enough to help us at the moment. We didn't see signs of improvement. There was an increase in confirmed cases. There was no additional financial benefit from Freetown towards districts. There were personal threats to our healthcare workers. There was police and military surveillance necessary in partner hospitals around us, and there was a lot of social distress. And the combination of these factors led to the fact that the international board asked us to leave 4 or 5 weeks maybe, just to see how the situation changes in Sierra Leone. If it gets better, you go back. But I'm still here. It's not getting better at all. And the hospital is still closed. This is our hospital. We are working very hard to find funds. We're very hard to go back. And most likely, Bart and me are going back the week after next week. Thank you very much.
Thanks very much, Victor. Any questions? I think we have a lot of questions, so we need to pick up just a few because it's tea time already.
Thank you very much. I'm a colleague of you. I was in Serabou. Maybe you heard about Serabou.
Yes.
Until end of May. And I must say, we were part of the Kappa Care program as well. Our hospital is still open, and we have the marvelous fact that we had until now only one confirmed case of Ebola. It is not surgically functional anymore. We have very, very few patients, but with the same entrance check, what you have described, it is still working. It has few patients, but it is still functioning. And I have a question.
Yeah.
Sierra Leone has 6 million inhabitants, and we have so far around about 6,000 Ebola cases in Sierra Leone. So this makes a risk ratio of 0.1%.
Yeah.
Do you have any figure about the risk ratio of the health personnel? So how many people, how many health personnel there is in Sierra Leone, and how many of them have died because of Ebola? Do you have a figure?
No, I don't have the figures myself. I don't know exactly how many healthcare workers there are and exactly how many are infected, confirmed positive, and how many have passed away. If you look overall at the outbreak, then you see that, especially in the beginning, up to 10% of the patients were healthcare workers. But it's combined for Sierra Leone, Liberia, and Guinea. And now you see a slight decrease in the amount of healthcare workers being infected. It has to do with the international response, more and more training. So luckily you see a small decrease in the amount of healthcare workers infected. But if you really ask me on the person about Sierra Leone and numbers, then I cannot give you that answer. I'm sorry.
Okay. Any other questions? I think, thanks very much, because I've had the advantage of seeing these slides much earlier. And the time when I saw them, I realized that it made much more sense to me than all the protocols that I could find on the internet, because this was really basic, but it covered almost everything that is required to create an isolation loop. And I think this is something that we need to share with the much more smaller hospitals and smaller, health centers. Yeah.
So what we tried to do, we have partner hospitals. So we invited, but it was just by people that you know. So we invited people over from McKinney to come to our hospital to have a look at our isolation unit, and then we sent somebody from our hospital to their hospital to actually rebuild the same isolation unit in their hospital. So we tried to expand it. And that's maybe a more critical remark, because at the moment I'm working as a medical consultant, like in between jobs, and I'm traveling around to help to set up isolation units in other hospitals and other countries, especially in Nigeria. But even for me, it's so extremely difficult to find the right information. If you go to the website from CDC or from WHO, there's so many guidelines at the moment that I don't even know anymore which one is the right one. And I don't understand why it's not more like a collaboration between the big organizations, bring out one protocol which is applicable to all the hospitals instead of having 50, 60 different guidelines at the moment.
A very quick response to that there are so many guidelines even before WHO took out the guidelines.
Yeah.
And WHO is the whole department which is addressing Ebola, and that they are the ones who put together the PPE guidelines, if you know, after all the different guidelines. And they're also putting the clinical guidelines. What is, I think everybody to share that also the surgical guidelines will be put, which will be added to the clinical guideline, and all of you will be part of that, because we will put some very basic thing just like you have.
Yeah.
Because even for surgical guideline, every other, either individuals organizations and hospitals, and you would have seen many of them on
Yes.
the website, are making their own guidelines. And believe me, I'm in communication with surgeons, and the two I know countries best is Liberia and Sierra Leone, because I was also there in May and in June. So I've been talking with them. This PPE thing, it's very, very tough, so nobody operates. They're not operating with PPE. They just wear the normal mask until, in fact, Wednesday, I was talking with them. And it's very tough. You cannot work with PPE if you're going to be operating. Number one. Number two, I've shared that, I think, with the Global Initiative members, that one is the fear as well.
Yeah.
They are only doing emergency surgeries. And with the result, what is happening is, when you don't do the elective, there's a whole lot of backlog and complications.
Yeah.
For example, hernias, appendectomies, etc.
Yeah. I think somebody in there can give a very good comment. Dr. Håkon from Kappa Care Surgical Training Program.
Last comment.
Thank you so much. I'm Dr. Håkon. I'm chairman of Kappa Care, the organization with the surgical training program. So we used when we had to close for clinical rotations, we used the students to go around to hospitals in Sierra Leone and gather data on admissions, surgeries, and hernia repairs and cesarean sections. And what we found, we visited 60 hospitals, which is all the hospitals, governmental and the NGO hospitals. And in October, we are just analyzing the data now. In October, 40 was open, 20 was closed. And in those 40, we could see a reduction on 70% in admissions from May, when the Ebola outbreak started, and until October. 70% reduction. And that's actually an underestimation of the real impact of Ebola. So we're hearing about this collateral damage of Ebola to other diseases, and it's substantial. The reduction in surgery was less, actually. We found a 50% reduction in total surgeries, and a lot more reduction in hernia than in cesarean sections. So that's share with you a little bit the findings of that study.
Thanks very much, Dr. Now, we come to the end. Thanks very much for the presentation, and I think this has been very helpful to us. And you get the famous cheese slicer.